So yeah, pathological cure usually indicate previous myocardial infarction due to irreversible myocardial necrosis. And what is myocardial necrosis? It has to, myocardium is the heart muscle. If you remember when we were treating the introduction to the heart, that was like our first topic, which I'm sure you people have forgotten. So myocardial necrosis has to do with the death of the heart muscle cells caused by prolonged lack of blood supply. When there's no blood flowing to the heart, the heart muscles are not going to get enough blood, and then little by little they begin to die, and then that's what happened to that's what is happening basically in myocardial infarction. And then they can help. Okay. So now, not all infarctions actually produce Q waves. Okay, so for MI, this MI, I don't want you to dwell with it, but I had to bring it up here so that you understand. Because when we get to ST elevation, we're going to be doing myocardial infarction and myocardial ischemia. So is ST elevation, that's like the confirmatory this thing. After you have seen, okay, I saw an abnormal Q wave. Now you have to check the ST segment. Is it elevated? Is it depressed? But we're going to get there. So that is telling you that it is not, there are some things that you see, or there are some clinical correlations, because we're beginning to get into the really serious ones now, that it is not just like we're going to treat heart blocks here now and then hypertrophies. It is not only one thing that will signify that this person has this thing. Just like it is not just an abnormal Q that will tell me that my patient has myocardial infarction. I need to also check other things on the ECG to confirm if the patient really has myocardial infarction. And the other confirmatory lead for myocardial infarction is in ST segment. And then we're going to get, that's like going to be the, maybe towards the last topic. So moving, do you guys understand everything I've said up till now? Oh wow.
Yes, ma'am.
Everybody in the class, do you understand?
Yes, ma'am.
Yes, ma'am.
The females, I've noticed you guys don't used to talk. Do you people understand? Shakirat.
Yes.
We
Okay.
understand.
Esther. You understand? And Philomena, are you there?
Ma?
Did you change your email?
Yes, I changed my email.
Oh, okay. Is this the one you are using now?
Yes.
Please reach out to Freedom so that's going to correct it on your this thing.
All right, ma.
Alright. So moving on now. We are now going to move to Q. Sorry, I'm really sorry. Oh, thank God. Sorry, I'm coming. So I'm going to be moving to the QRS height now. Okay. I'm coming. Let's look at some. I searched for some things on abnormal QRS. Or did I not? I think I did though. I don't like it when these things here. It's really stressing me. Abnormal QRS. Sorry, abnormal Q wave. Um, I don't ask you the meaning now. Pastor prayer myocardial infarction at attack basically. Let's see. Okay, I think it was here. No, so we want to see our I don't like this one. It's going to be, let me see. Okay, so we're going to be checking the one, the two, the three, our let me see. Are you kidding? QRS, lead 2 with 3, and then AVF. Can you guys see what I'm showing you? Can you guys see this lead?
Yes.
Okay.
Yes, sir.
So this one
Which
is
one of this one? Which one?
who is that? Freedom.
Which one? Yes, which one are you showing us?
I want to show you now.
This is the one that
Let me show you. It's obviously obvious. Look at your QRS. Look at the QRS. Sorry, this is the QRS complex. This is your Q, R, and S. Look at this Q that they told us that it should not be deeper than 2. This is like 6. Who is that is unmuting his own mic? So this is like 6, right? That's is abnormally abnormal. Okay. Now it is lead 2, right? Let's check lead 3. Now this is lead 3. And then this is AVF 2. And I told you that you are going to check the leads that are in the same position. Please, can somebody tell me the position of lead 2, lead 3, and AVM? I mean, if few people have actually been listening in class and I've not been wasting my strength. Tell me the position of lead 2, lead 3, and AVF. Anybody? Is it lateral? Is it posterior? Is it inferior? Is it anterior? Oh God. I'm waiting though, or else we're not going to continue this class today.
please explain again.
I said, tell me the position of lead 2, 3, and AVF. Are they lateral leads? Are they posterior leads? Are they inferior leads? Or they are, what's that? Anterior, posterior, lateral, inferior, yeah. Something
They
like,
are inferior.
finally, thank God.
Man, please, I don't understand you too.
Let me show you again. Because I said it in this class. Oh. So what I just said now. Inferior, lead 2, lead 3, AVF. Anterior, V1 to V4. Lateral, 1 AVL, V5, V6. Posterior,
Oh,
V1 and
oh,
V2.
oh, I
Multiple.
understand you now.
Okay, ma. I don't really understand now, but I understand.
Oh, Eshe. The person that answered, who is that? Who is that? What's the name of person that answered? You don't even want to give you gifts. Okay, I'll keep my gift.
I'm the one. I'm the one.
I'm the one.
Esther.
Who is the one? Okay. Which Esther is that? Is it Aderibigbe Esther?
Yes.
Okay, no problem. Freedom. Freedom.
Ma, 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 ma,
Remind me that Aderibigbe
ma.
Esther has a gift with me. Oh.
Oh yeah, ma.
Yeah.
I used to get questions very well. You
I
don't give
don't
me gift.
today I just feel like giving gift now.
Ma, it's not fair. Ah, it's not fair. It's not
Yeah.
fair.
Help my leg. Please tell her to I be reach out to me on her behalf. And if you like, don't reach out. So
Ah,
let's look at this wave now. I'm coming. Oh, I'm seeing something. Who is eating? So I'm seeing something in lead 1, lead 2. I don't know if you guys can see this lead 2 very well. This is about 3. Can you guys see it?
Yes, ma.
Okay, I'm coming. Let me see if I'll see another one that is clear. But lead 1 and 2. Okay. Let me see if I'll see another one that is clear. AVL. Okay. It's also in AVL too. Now looking at this wave, this is your key wave. Sorry that this is I don't know, the ECG is actually abnormal here, so I don't know if you guys will be able to interpret things. This is like an ST, there's an ST elevation here. Don't worry, don't let me scatter here. Let's see if we see another example of V1 to V4 coming. with ST elevation coming. Okay, now so this is actually your first negative deflection, like I told you before. It is your what? It is your Q wave. And now looking in this place, this is we have like a small P wave or whatever wave here, and then this our first negative deflection is our Q wave, and you can see the depth. This is totally, I mean, this patient, I mean, I don't know the owner, but then it's really really abnormal, and they were having V2 V3, and I told you that V2 V3 V2 V3 should be should they yeah, should be anterior, or even yeah, it's the anterior leads. Okay, so this person possibly is having anterior MI, but I'm not going to interpret that, okay, oh, my patient has anterior MI, like sharp like that, because if you check what they wrote here now, anterior Q waves with T wave inversion, there has to be something else to give me the confirmation that, okay, I can actually go ahead. Yeah, my patient has MI. And also there are also some tests that they will do, that a patient will do to confirm myocardial infarction apart from ECG, because that's why we have echo test, that's echocardiography. That's like a confirmatory test that yes, this is like correct, okay? Because sometimes they don't really trust ECG like that. Most people like come to hospitals, they will tell them to do ECG, then they'll go and do echo. ECG just tell you what possibly can be happening to your patient, and then echo test tell you, okay, this is what is actually happening to my patient. The doctors will ask the patient to do both tests in order to be really sure, okay, of those things. And then echo is like a really more difficult and then requires a larger process and even very expensive than ECG. So moving on, let me send this image to the group, or even the site link sef.
Ma, I hope you are screen recording.
Yeah, I am. It's like it's even
So if you are screen recording, it's like it's already about another 10 minutes now.
exact.
Even if not more than,
Yeah,
it's more than now. It's like 10 minutes.
okay. um where is this image? What is it? Subhanallah, sorry, I'm trying to send you the link to the site so that you guys can go and practice it, and for those that are not here, they will see the video sha. um yeah, so yes, that's the site. So let's just move on to QRS height. Now, after dealing with our Q wave, we're going to move into the QRS proper. Now, your QRS, like every other thing, has to have a height and then has to have a wideness. So now, talking about the QRS height. Now, we're going to be dealing with the height first. Your QRS height reflects ventricular depolarization. I mean, QRS itself is actually ventricular depolarization, like we know. Now, the normal height for your QRS for limb bleeds. Can anybody should mention limb bleeds for me? Mention the limb bleeds that we have.
AVR,
AVR, AVL, AVF, neutral.
Thank you very much. I don't have gift for you.
Lean boots.
Mine is a way when I answer the question. Only.
I beg. So your normal height in limb bleeds should not be more than five. Five small squares, I mean. And the normal height in chest leads should not be more than 10 small boxes. For your limb bleeds, AVL, AVR, AVF is 5. And then for your chest leads is what? V1, V2, V3,
10.
V4, V5, V6 is 10. Yeah, thank you very much. And sorry, this greater than Subhanallah. Okay, sorry, I'm very, very sorry. Is greater than or equal to 5 millimeter. That's 5 small boxes. And greater than 10 small boxes. Is not less than. That's like way too much. Is greater than or equal to 5 and less than and greater than or equal to 10. That is in chest slit. And now there's something we now call hypertrophies. First thing first, once you see a patient ECG, check the chest slit. Check the QRS complex of the chest slit, especially the R waves. There are some cases that the R waves they will be tall. I mean, they will be as tall as they will be entering each other. Like the one for V1, I'm sorry, the one for like V5 can will be entering the one for V4, the one for V3 will like be entering the one for V2, like Omati gone. And now tall QRS complex represents hypertrophies, ventricular hypertrophies. So first things first, when you see a very, very tall QRS, especially in the chest lead, know that your patient is likely to have a ventricular hypertrophy. Now, what kind of hypertrophy? There's left ventricular hypertrophy and then there's right ventricular hypertrophy. Now, left ventricular hypertrophy has to do with tall R waves in what V5, V6, or AVL. While right ventricular hypertrophy has to do with tall R waves in just V1. Now, right ventricular hypertrophy is just the definition is just the thickening of the right ventricle due to too much pressure. And then, what will you see on your ECG that you know that my patient has right ventricular hypertrophy? No, the first thing is that the R wave in V1, the R wave in V1 is going to be greater than 7. The R wave in V1. You know, I said it's supposed to normally supposed to be greater than or equal to 10. That's in chest lead. Now, for R waves in ventricular hypertrophy, your V1 has to be greater. If it's greater than 7, if your R wave is greater than 7 in V1, or your R wave is taller than your S wave, because in V1 what you are supposed to see is S wave being taller than R wave. So if you now see like an opposite of when your R wave is taller than your S wave, there is right ventricular hypertrophy. Or when you count the number of R wave in your V1, you are seeing more than 7. It is also ventricular hypertrophy. But it's not only that. You now have to check your V6. If your S wave is like really deep, V5 or V6, if it's deep, if you have like a tall S wave, it is also an addition to ventricular hypertrophy, right ventricular hypertrophy. Another thing is if you see right axis deviation, which I know you already know how to recognize. I'm sure you know how to recognize right axis deviation. It's also right ventricular hypertrophy. I'm not saying right axis deviation is right ventricular hypertrophy. I'm saying that when you have seen your R wave in V1 that is greater than 7, or your R wave is taller than your S wave in V1, or there's a tall S wave in what? In V5 or V6, you will not see right axis deviation again. That's the third confirmation. Now the fourth one is that it has to be a right atrial enlargement, and I told you that P pulmonale is the one that is caused by right atrial enlargement. That means you have to be seeing a P wave that is taller than 2.5 small boxes. Coming back again, four things that will tell you that your patient has right ventricular hypertrophy. There's a tall R wave in V1 that is greater than 7, or in that same V1 your R wave is greater than your S wave. Now, in that same lead, there's a tall S wave in V5 and V6. Another thing is that there has to be right axis deviation. Another thing is now that it has to be what? Right atrial enlargement, which is tall P wave. Now, what causes right ventricular hypertrophy? Pulmonary hypertension. You know, I told you that ECG can actually make you know that your patient is having hypertension. Now, this is where we're already getting there now. What can cause right ventricular hypertrophy? Hypertension, pulmonary hypertension, chronic lung disease, or congenital heart diseases. So when your parents have either of these things, then you begin to see symptoms of right ventricular hypertrophy. Now that's right ventricular. Please don't mix it up. Now moving to left ventricular hypertrophy, this is where you begin to calculate because you are going to count your leads and then start adding them. And I trust me, in real life, this is what you are going to be doing. You are actually going to be calculating. Now, there are two or methods or criteria of looking for left ventricular hypertrophy, and you can check anyone. You can do anyone. The reason for this is that if you see your tall P waves, sorry, your tall QRS, and you calculate it with one criteria and it did not work, calculate with the rest. Okay, that so that you know say that tall P wave, my P wave is tall, my QRS is tall, but when I use one method, it did not add up. So my patient does not have left ventricular hypertrophy. No, you have to check all other methods. That's the reason for this multiple method in left ventricular hypertrophy. Now there are two. The most common one is this Sokolo-Lyon. They call it Sokolo-Lyon criteria. Now for Sokolo-Lyon, you have to check your V1, S wave in V1 plus R wave in V5 or V6. There's something about V1 to V6. From V1, there's something you need to hold. V1, your S wave has to be taller than R wave. Okay, so Omama Gun, like it's going to be tall. For V2, it's going to be reducing, and then your R wave is going to be increasing small small. V3, S wave is going to be reducing, R wave is going to be increasing. V4, S wave will be reducing, R wave matima go see. So that thing will be V5, V6. You know now see you be seeing short S wave and then like really tall R waves. Okay, so now you check your V1. Check for S in V1 because S is the one that is supposed to be tall in V1 plus R that is supposed to be tall in V5 or V6. Add both of them together. They must not be more than 35. If they are more than 35 small boxes, there's a problem. Count the number of small boxes that S occupies in V1. Count in R wave in V5 or V6. Both of them, add them together. They must not be more than 35. More let us check examples. Um this is okay. This was right. Let me can you see now? There's right axis deviation, there's dominant R wave in V1 greater than 7, there's dominant S wave in V5, V6, then the QRS duration. Okay, so now usually caused by mitral stenosis, pulmonary embolism, pulmonary hypertension. Now I said that what your right ventricular hypertrophy in V1, R wave must not be taller than 7, and it must not even be taller than your S wave. Now Ekawa will be this is where is it? Okay, this is V1. This is R wave and this is S wave. Can you see that there's already one problem here? Because your R wave is already taller than this is your S wave and then this is R wave. R wave is already taller than S wave. But let's still count it. This is let me I don't know. I'm trying to zoom it. Aha. Can you got him on zoom it? Can you guys see it?
Yes, ma'am.
Alright, thank you. So if we're counting here, this is like 5, then 5 again, that's 10, plus this 2 here, that is 12. Our R wave in V1 is 12, and it's more than 7. So totally, like your patient actually has left ventricular hypertrophy. That's already one confirmation that, sorry, right ventricular hypertrophy, one confirmation that patient may need right ventricular hypertrophy. Now, check our loss, see right axis deviation. Check lead 1 is negative, check lead 2 is positive. And I told you that lead 1 negative, lead 2 positive is what? Right axis deviation. That is another thing that you have to know. Yeah, my patient also has right ventricular hypertrophy. Now, checking, I'm coming. Let me check this P wave. If it is greater than 2.5, I don't know. This is it. I don't know. This is like three small boxes, but it's not totally. It's not. It's get like 2.5 to three small boxes, and we said it's 2.5. So that's another confirmatory. Say confirmatory, be confirmation. Confirmation that your patient is likely to have right ventricular hypertrophy. So I said right axis deviation, right atrial enlargement, the P wave, the R wave more than 7, and we have seen that it's actually 12. Another thing is checking your V5 and V6. Is there deep S wave here? Actually, there are deep S waves here. Sherry, only this S wave, 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 this S wave. They are deep in V5 and V6. So confirm it, like right atrial, is it right ventricular hypertrophy is confirmed in my patient. So right ventricular hypertrophy is confirmed in this patient.
Sorry, my lady,
I'm
it's
quite
already 10 minutes.
okay. Do you guys understand? Who is this? It's not easy before. This is not play. So do
Yeah,
you guys?
ma, is we understand. I do not taking.
You do know what?